So I'm going to talk a little bit about the evolution of robotics and spine surgery. At the University of Virginia, we got our first the Mazor X almost a year ago in February 2019. So I just wanted to go through some of that. I think a lot of these news articles and headlines you guys have all read before, sort of suggesting the future of surgeries and robotics, and that's the next step, and may even take over a surgeon's role as well. Certainly, there are other headlines that even show that robotic surgery may not be the best approach, and everything in between. There are a lot of companies out there that have spent millions to billions of dollars developing robot systems, and we'll talk a little bit about that as well. So this is called the hype cycle of emerging technologies, and it sort of shows the different variations of where emerging technologies appear on the curve, anywhere from the first thought of a potential technology called the innovation trigger, to the peak of inflated expectations, to disillusionment, and then finally the slope of enlightenment and the plateau of productivity. And so you can see, based on this curve, we have a lot of different things, but robotic surgery is also on one of them too. The question is, where does it lie right now? Is it sort of in the peak of inflated expectations, or is it slowly getting to the process where it can be used ubiquitously? What's the global market for robot surgery? This is sort of a management consulting company that basically did a lot of studies on the use of robotic surgery in general and all different subspecialties that showed that the global share is approximately $5.5 billion in 2018, with an expected global market share by 2025 of greater than $24 billion, with America and Germany being two countries that would most use them. The compound adjusted growth rate is anywhere from 24 to 25% during this time period. So robotics in medicine, there have been many different robotic systems that have been applied to various subspecialties. One of the most common, of course, is a Da Vinci, used in urology, gynecology, and general surgery. But again, you have robotics that are being developed in all different subspecialties. Of course, the Da Vinci was, in 1999, was launched partly with funding and development from DARPA, or the Defense Department in the US. And by 2018, there are greater than 5 million cases completed by the Da Vinci, and more than 4,500 worldwide cases. This graph is also from a management consulting company, Goldman Sachs, and they essentially predicted that an expectation of 1,600 orthopedic robotic systems, including spine, by the year 2020, generating over $900 million worth of new sales, mostly in the US, but also in installed systems outside the US. Again, other graphs sort of indicating the growth of robotic surgeries. In 2012, at least 500,000 or so. And again, the market share continues to rise. Contributing to that is also the research related to robotics in medicine. This is an article from 2016 that did a query of publications, 3,300 or so, and in the last decade, greater than 570% increase of publications. So where does that lead us in neurosurgery? I think to have a very good robot system, you also need to have good image guidance. And just a little bit of history. In 1986, David Roberts was one of the first who connected a stereotaxic system to his microscope in order to localize lesions within the brain with pretty good accuracy. In 1987, one of the first navigation systems was used in Japan. And this is sort of the prototype that's been used in all cranial surgeries. At least in the US, there are very few cranial surgeries that are done without this navigation system. Of course, we know the CyberKnife radiosurgery, and John Adler was pivotal in terms of the robotic system and pioneering the radiosurgery. So what are the current indications of robotic guided spine surgery? They include spinal fusion, mainly pedicle screw instrumentation, but also can include transfacet and translaminar facet screws, as well as SI screws, spinal deformities, cement augmentation with kyphoplasties and vertebroplasties, as well as certain oncological applications, including biopsies. But there are really future applications as well, including tumor resection, osteotomies, direct lateral approaches, as well as anterior lumbar approaches, and dural repair as well. So why robotic surgery? It all has to do with patient safety, inevitably, and the decrease in complications. Whether that's true or not, we'll talk about. But there's certainly limitations to fluoroscopy. Radiation exposure is one of them, both to the patient, the surgeon, and the OR team. Positioning can be difficult. Upper thoracic visualization can be difficult as well. When doing MIS surgeries, you need two fluoroscopes, can also add to the workflow. And so essentially the goal for robotics and spine surgery is essentially to lower, it all comes down to patients. It's lower the intraoperative complication rate, reduce exposure to x-rays. The new and latest robots are merging image guidance, which you can then do preoperative planning before surgery, the day of surgery, instead of winging it on the day of surgery. Of course, there's applications to MIS techniques, those with challenging cases. And as we talked about, there is an element of marketing involved with patients, depending on where you are in the world. Certainly there's disadvantages, as we were talking about, workflow limitations. It does require a larger surgical staff, support personnel. There is a learning curve and a cost associated to it. We can go through all the different articles that have been published in terms of the accuracy, but essentially navigation by itself is around 95%. Robotics, there have been reports of increased accuracy to about 98%. Why do we use image guidance? One of the largest spinal payouts or lawsuits in America was from Detroit for about $135 million after paralysis on a patient. And this is what we're trying to avoid, a misplaced screw. And so that has to do with higher accuracy and high precision, and that's really the goal within spine surgery. For those of you who've done image guidance, a pedicle screw placement with whatever system, you know that there is an attention shift during surgery. Once you are ready to place a screw, you're always looking towards the navigation screen, not necessarily at the patient, and there can be a learning curve associated with that, and also issues that can arise. So the ideal robot system really marries imaging, surgery, and robotics, and so you really have to have a system that's capable of image guidance as well as the benefits of robotics. This was an editorial published in JAMA, the concept of medical robotics and the ethical and legal considerations. And you can see there's different stages in robot development, from no autonomy to full automation. Of course, robotic spine surgery, if it will ever be like that, I'm not sure in terms of full automation, but it's sort of a concept of cobots where robots and surgeons are using robots in order to do things that are safer. There are three different categories of robots: supervisory controlled, telesurgical, and shared control. And most of the robotic systems in spine surgery right now are shared control, where the surgeon and the robot have simultaneous control and the ability to control the instruments and motion. So I just wanted to briefly talk about the different robot systems out there. The Spine Assist, which has been transitioned into the Renaissance and the Mazor X, was one of the first systems that was approved by the FDA in 2004. Again, that's a shared control robot. There was it automatically positioned its arm along a predetermined trajectory, but there were some downsides to it, including a large mounting frame, as well as tool skiving and sliding. The Renaissance replaced the Spine Assist in 2011. There are many software and hardware improvements related to it, and the ability for surgeons to alter the anatomy prior to placing screws as well. Fast forward to 2016, where The Mazor X was developed and eventually bought by Medtronic. This was a solely robotic arm that includes, you can see here, a linear optical camera that allowed a volumetric assessment of the work environment, which led to this concept of trying to avoid collision during surgery. The software is such that each of the vertebral bodies are registered independently, and it allows for an increased range of motion and compensation for patient movement intraoperatively. The Globus Medical Excelsius GPS, which was developed with Nick Theodore, who's at Hopkins, was cleared by FDA in 2017. It also provides real-time intraoperative imaging, as well as haptic feedback and error alerts if there is issues with image registration. This is a review article in terms of clinical outcomes and accuracy of robotic-assisted pedicle screw placements. You can see here that the outcomes are very good in terms of improved accuracy and no difference. There's only one paper that was published in 2012 of 60 patients that stated there was reduced accuracy. Again, accuracy can range anywhere from 95 to 100%. In terms of radiation exposure, I think there are many articles claiming that there's reduced radiation exposure. I think the potential is there, but there is, again, those learning curves with these new techniques. There were 2 articles in this review where they demonstrated decreased radiation, 2 that did increased radiation, and 2 that were no difference. In terms of operative time, again, increased operative times were noted in 2 of these review articles and no difference in others. I think that has to do with the learning curve associated with it. When we look at the natural history and progression of robotics and surgery, I think it lends well to what technology and how it's evolving in our hands right now. And I think as generations go on, there will be a role for robotics, and how involved that will be, time will tell. So a little bit about the Mazor X. It's something that can be used for all different types of spinal surgeries, including trauma, MIS, and spinal deformity. How does it work? Essentially, there's a preoperative software that you can input CT scans and plan trajectories with pedicle screws, and then execute the surgical plan with robotic guidance. You can see here the software system on the right. Once an imaging is uploaded, the software automatically suggests and recommends screw trajectories and screw lengths, which then can be optimized based on the surgeon's preference. Certainly, this is very helpful for small pedicles as well. The robot is then mounted on the bed and affixed to the patient. As we mentioned, the 3D camera sort of outlines the surface analysis in order to calculate what the no-fly zone is, and then 2 fluoroscopic images are done in order to merge the robot and the CT scans to the intraoperative environment. Finally, the pre-planned trajectories are calculated by the robot, and then the surgeon can put in the various instruments in order to complete the surgery. So just a couple cases from UVA. This is a 72-year-old with idiopathic scoliosis. You can tell with prior laminectomies and minimal relief. Very small pedicles, rotated, often makes fluoroscopy. It can make fluoroscopy more challenging, and so this is where robotic assistance can be very helpful. You can see the software planning in screws for these small pedicles, and these imaging guidance can be used in real time in order to sort of check after screws are placed to see if they line up with the plan as a means for real-time feedback. Again, a software that calculates all the screws. The software is very intuitive as well. You can see the rotational angles calculated between L1 and 2, all the different parameters that the speakers have talked about previously can be calculated in the software, so you can get a final plan of what your surgical goal is. And so this is sort of the final product after surgery. This is another case, a 71-year-old with progressive coronal imbalance, pain, and disability. This is particularly helpful for S2AI screws. As you can see here, it can be planned accordingly. Again, those spinal pelvic parameters can be calculated with the software. What's nice about more challenging screws, including these, is you can line them up, the starting point, so that when you need to place your rods, they can be lined up perfectly as well, making the surgery a little more easier. This is just a video that I'll forward through with attachment of the surgical arm to the spinous processes at about the lower thoracic area. Once that's done, fluoroscopy is done to synchronize the imaging in order to do the navigation. These are the two fluoroscopic images that are done. And then I'm just going to fast forward through the planning software. So you can see that the superimposed screw is already in place. And when you're doing the various instruments, you can see how they line up in order to get real-time feedback in terms of how these screws are going to be placed. And this is sort of that image too, trying to match the screw that's being placed to what's been planned already. And this is sort of the final product. So this case is a 48-year-old with worsening L5 radiculopathy and scoliosis. She was trying to delay a deformity correction. So the L5 radiculopathy was going to be treated. And so this was done actually by my colleague, Dr. Avery Buchholz, in a minimally invasive way. So once this plan is made, you can also line up skin incisions so that the optimal, again, surgical plan is created. And he did this in a way where the patient was positioned laterally, so both surgical teams were working at the same time, where the general surgeons were getting access to do an interbody fusion anteriorly, while he was placing screws posteriorly with the robot in the lateral position. And this ended up working well. It's more efficient for the OR as well, and this is the final product. And again, you can see how the preoperative images with the surgical plan can be compared with intraoperative or postoperatively to see sort of the accuracy of the screws and whether they line up with the plan. Certainly there's cost of robotic spine surgery. There's the cost of the surgeon's time, but really for MIS cases or 1 to 2 level degenerative cases, it really only takes 5 to 10 minutes to plan this out. Obviously for deformity cases, it's much longer. There's a learning curve associated with it. A paper in 2015 with 1,200 screws placed by 13 surgeons basically showed that you need at least 25 robotic procedures in order to overcome that learning curve. Similar study in 2014 showed a revision rate of 17% to 7% after 13 cases. The hospital costs, the capital costs are anywhere from $500,000 to $1 million. But when we look at that, again, the goal is accuracy of screw placements and avoiding complications. This was a paper that was published in terms of looking at radicular symptoms after screw placements at about 10%. So 10% develop new neurological injury. In terms of needing revisions based on freehand versus robotic, there's certain literature out there that you can save certain number of revisions in surgeries. And you look at the cost of revision of surgery can be close to $30,000. And the economic evaluation of all the things associated with revision can be upwards to $150,000. So when you calculate all that together, there is some cost savings associated with robotic surgery. Again, it depends on what country you're in and what the economic situation is. So when is the robot-assisted spine surgery most beneficial? I think when it relates to complicated anatomy, severe deformity, congenital anomaly, or previous surgeries, definitely morbid obesity and minimal visualization cases, such as MIS cases. So in terms of conclusions, I think robotics is really a frontier in terms of spine surgery. Initial clinical studies suggest that it can provide more accurate and more efficient pedicle screw instrumentation. There is a learning curve with all this type of technology, and efficiency and workflow is key. It does require a team. It's not just a surgeon, him or herself. each spine center has their own individual needs, and some may not, need robotics, or at least at this time. And they're definitely, as with all studies, further, larger prospective studies are needed to really understand the complications, the outcomes, and the costs associated with it. Thank you.